Hello. Let's look at Chapter 101 on pharyngitis and tonsillitis. Definition of pharyngitis is an inflammation of the pharynx from either inflammation or irritation or infection. Tonsillitis is an acute or chronic inflammation of the tonsils and is usually a result of the beta hemolytic strep, so Streptococcus. And for the rest of this lecture, we're going to call beta hemolytic streptococcus gas, okay? That acronym. The epidemiology, look at the significance of this. About 6% of all primary care visits are related to pharyngitis. They can be either acute or chronic, infectious versus non-infectious causes. Our non-infectious usually is referred pain, allergies, burns, cancer, or irritation. Infectious is caused by the pathogens of viral bacteria, fungi, or parasites. Bacterial pharyngitis most common in children, about 30 to 40%, peaking at between age 5 and 15. Number one causative agent is S. pyrogenes. But look at those other infective agents on page 413. They're also significant. Viral pharyngitis is the most common in all age groups, but about 30 to 60% of tonsillitis pharyngitis in adults is a virus, and the virus responsible is rhinovirus. So the pathogenesis of both pharyngitis and tonsillitis results from exposure to a virus or a bacterial agent, although some patients can harbor or be colonized by one of these pathogenic bacteria and remain infectious free. Clinical presentation, it really depends on the varying or offending agent, okay? Non-infectious, these people complain of sore throat, dryness. Infectious, which most commonly are viral, and if it's bacterial, the gas or the S. pyrogenes, the symptoms are similar. Their throats hurt, they have a fever, they're tired, malaise, cough, headache, myalgia, kind of muscle ache, and fatigue. You keep in mind that about 15 to 25% of children less than 15 years of age are infected by the gas. Transmission is direct contact, and there's about a 2 to 5 day incubation period. So in the physical exam findings, really for the virus, you're going to see, you might see a fever, cough, nasal symptoms, mild erythema, little or no exudate. That's a tip. The pharynx is swollen, boggy, and pale. Bacterial, particularly the gas, is marked erythema of throat and tonsils, patchy, discrete, white or yellowish exudate. You can see petechiae, tender anterior adenopathy. Previous gas patients may have scarlet fever, sandpaper rash, or an erythematous tongue, a strawberry tongue. Tonsillar pillars have purulent drainage. The uvula is edematous, and fever is greater than 101. On occasion, persistent sore throat with little fever and no exudate. Now, isn't that confusing? So you have those variants, but typically you're going to see what I said above. Diagnostically, clinical presentation may indicate the diagnosis. And again, just knowing the difference between the typical and keeping in mind that on occasion you have these variants. There's really no test for viral infection. It's usually just a rule out in case you're not sure. For the gas infection, throat culture, rapid strep, or an ASO titer can be used. Usually, if you're really suspicious and you can obtain both that rapid strep and the throat culture at the same time. This just happened to a colleague of mine whose child's rapid strep was negative, but she insisted on the throat culture, which was indeed positive. Okay, and then I want you to be familiar with the centrocriteria in adults. It's a good guideline. It's not something you have to use, but it does help you in differentiating. Management and treatment for viral pharyngitis, tonsillitis, it's really symptomatic. Fluids rest, humidification, voice rest, warm saline gargles, acetaminophen or ibuprofen if appropriate. Bacterial really need the same symptomatic relief as above for the virus, but they also need antibiotic therapy, which could be penicillin 500 milligrams 3 times a day for 10 days, or 875 twice a day for 10 days for the strep infection. Or some people give a one-time dose of benzathine penicillin. That's 1.2 million units IM. Page 415 also looks at other antibiotic choices when penicillin isn't appropriate and during pregnancy. So just look at those. Referral, really we will refer to an otolaryngologist for recurrent strep infections or complications caused by pharyngitis. And I also think airway obstruction or any kind of suspicion or abscess formation requires immediate referral. And we just had talked recently about peritonsillar abscess. So patient family education is extremely important, and adherence to antibiotic therapy must be stressed. Patients are infectious for 24 hours after that antibiotic start, and the full course of antibiotic are required to prevent reinfection or complication. This picture is really interesting because I found it through the American Family Physician, and I'm going to load in this module a very small case, and it's a photo case, and this is the picture that's involved. So if you have time, do that. It's quite interesting. Thank you.